You are now tuned in to the #1 nursing podcast in the world, the Scrub Me In podcast by Nurse Junior and Anthony.
You are now tuned in to the #1 nursing podcast in the world, the Scrub Me In podcast by Nurse Junior and
Nurse Anthony.
Make sure y'all like, subscribe, comment on YouTube. Follow us there. Instagram, we have an Instagram. What else? Facebook, TikTok,
Sir.
all that. Today is episode 23.
I don't know. I'm losing track.
Yeah. Bill, our editor, will figure it out. Bill will figure it out, and he'll put it right there. But today we have a special guest all the way from Cali.
Hey.
I'll let her introduce herself.
I'm losing you a bit there, but I think I did just introduce myself. So
Yes.
Yeah. Sorry about that.
hi. I'm Susan. I'll just use my name.
Yeah, that's fine. That's perfectly fine.
Yeah, that's totally okay.
That's perfectly. Susan, how long have you been a nurse? How long have you been a nurse for?
I have been a nurse since 2007.
Okay.
And I've always been a neonatal. I got into the job planning to become a neonatal nurse practitioner eventually.
Yeah.
I've kind of viewed the rest of nursing school as hazing.
Oh,
as
no.
Getting through to my babies. Big people scare me.
See, I feel like for most of us, babies scare us. If you're a lifelong adult, like nurse, I feel like anytime, like my wife's a pediatric nurse, so anytime she talks about peds and dosing and all these other things, I'm like, ooh, that's out of my realm.
Yeah.
Yeah, I feel the same way when you talk about adults. Like, they have teeth and they talk.
Oh, that's funny.
And that's just gross.
Yeah, I hear you.
And, babies are supposed to throw up and poop in their pants.
That's a fact.
And, that's normal for them. They can't help it. I mean, not that adult patients can't help it either, usually. But it's a lot less, gross when it's a baby.
Yeah, it's interesting.
They got those cute baby fetus just to go along with it.
It's interesting you say that because I feel like even though I knew getting into nursing, I'd be wiping a lot of ass.
Yeah.
I didn't realize how much until I got into it. It's a lot of ass wiping,
Oh yeah, plenty of it.
Yeah, I thankfully did not have to do a lot of it, only in nursing school, unless you count baby butts, and those aren't too bad.
No, not bad at all.
And you don't hurt your back with them.
That's a fact.
Very true. Very true. So 2007 is when you graduated. What led you to even want to get into nursing? Did you have family members that were in the healthcare profession, or how did that go about?
Yeah, my mom was a nurse.
Nice.
And she actually became a nurse when I was probably 6 or 7. And my mother-in-law at the time was also a nurse.
Wow.
And everyone had told me I'd be good at nursing, blah, blah, blah. But I didn't want to do what my mom did.
So wait, what kind of nursing did your mom do?
I got a degree. Because, that's boring. You want to do something different than your parents when you first go to school.
Well, what kind of nursing? What kind of nurse?
Yeah, what specialty was she
in? What unit was she on? Yeah.
Oh, she did ortho and OB mostly, I think.
Oh, wow.
Okay.
Two very different fields.
Yeah.
And she used to do physicals for health insurance companies.
Oh, yeah.
Okay, yeah.
At home. When my sister and I were still in school.
Yeah.
But my now ex-husband, stopped being able to work. And so we needed another job, and I had been a stay-at-home mom.
Mm-hmm.
And so we needed income, and not income that needed to be fairly regular. I have a degree in Spanish and international studies,
Wow.
which doesn't translate necessarily to steady work always, especially when you live in the Midwest. So I decided to go back and do this program where I could eventually become a nurse practitioner.
Nice. So how was the?
Sorry,
go ahead.
I was saying I am one of those kind of dreaded direct entry students. So I had a degree in something else. I went into nursing, and the program that I went to, you get your license to practice nursing, and then you go to work for however many years you want to before you finish. In neonatal, you have to work at least 2, and I worked 4. So.
Okay, that's interesting.
So I always have to say that, because most people think direct entry goes straight from school, undergrad to grad. It's actually just if you have a different degree than nursing as your first degree.
Wait, so you were working while you were in school?
I'm sorry, I missed the last part.
I said, so you were working while you were in school?
I was working when I was in the last 6 months of school. I was working a quarter to half time.
Yeah.
In my last 6 months of nurse practitioner school.
Oh, wow.
So can you explain?
And that was hard. I was spending 70 hours a day doing things, but
oh man,
it felt like.
Can you explain direct entry? So you mean, with direct entry, you had a different degree, is what you're saying, and then you went into nursing?
Correct. It's basically a program so I don't have to retake all of my humanities courses, because God knows I've had enough humanities courses to kill a horse. My biggest problem switching from humanities to nursing was, wait, you don't want my paper to be 40 pages long? And you don't want me to have any original thought? Okay, I could do that.
That's funny.
That's weird, but whatever. So with direct entry, I went to a large brick and mortar state university. You go in and you finish all your pre-licensure RN requirements at a graduate level. So all the classes I took were technically in the grad school, but it's still basically the same BSN classes that they have.
Right.
Got you.
And then they give us a little more clinical hours than they do for the regular BSN. And then we're allowed to sit for a licensure for an RN.
Mm-hmm.
And then we can go off to work and get some experience before we come back. And basically you just call them and say, okay, I think I've had enough experience now that I'm feeling good. I'm willing to move forward. So for a while, I was a Bachelor of Arts registered nurse.
Wow, I've never heard
Interesting,
of this before.
yeah.
So, and then
So it's a barn.
So let's say when you go back after, I know you said the requirements was 2 years, but you did 4. So when you go back after your 2 or 4 years, you go right into the NP program?
Right. When you were accepted to school initially,
right.
You are accepted into your specific track. So obviously mine was neonatal. So when I started nursing school, I knew eventually someday I was going to be a nurse practitioner.
Wow, that's incredible.
Wow, yeah. Didn't know that.
I didn't know that they had those.
And the way in some ways it's kind of good, because even with the nursing classes, since all of us are in a track to eventually become a nurse practitioner, they teach you the nursing answer, and then they're like, and what will you say when a nurse calls you with this question in 5 years?
Wow, yeah, I guess that's how you'd have to be taught.
And, we didn't always know the answers at that point, but it helped keep us thinking about more than just the individual answer and task.
Absolutely.
Mm-hmm.
So then those 4 years you worked then as an RN, while you're working, are you thinking to yourself like, oh, when I become an NP, these are things that I need to know, and like you kind of prepare yourself even while you're working for your program, I'd assume?
Kind of. I mean, honestly, for the first year or two, just like any new grad nurse, you're just trying to get your feet underneath you and feel good about what you're doing.
For sure.
You always feel like an idiot when you first start.
Always.
And you don't have your time management skills yet, and you're just always feeling lost. But then as you start to relax more and know what you're doing, then you can say, okay, obviously when you're a bedside nurse, you're not making any decisions still,
Right.
but you can think about and try to guess what they're going to say.
Right. Yep. I agree with that.
So while you were doing like the RN undergrad portion of your grad program, how long does that take to complete from start to finish with a degree already before?
I had to do some prerequisites too, because I had a Bachelor of Arts. I was a little light on the sciences, so I had to take micro anatomy and physiology and pathophysiology.
Right.
Just those kind of basic courses to give you a standing. So that was probably, I didn't take those all at once. So it was probably a year, and then it's a good year and a half of double full-time graduate work. So normally, like, you would have 8 credit hours to be considered full-time.
Mm-hmm.
You were taking 16.
Wow.
So I would be at school from 8 in the morning to 9 or 10 at night sometimes.
Wow.
Good for you.
And so at the time, did you have kids at
Yeah,
home
it was
as well?
desperation.
Yeah.
What was that?
Did you have kids at the time as well?
I did.
Wow.
My daughter was 3 when I first started taking classes, and that was hard, and I still carry mommy guilt from that. Because I kind of abruptly had to go from being a stay-at-home mom who was working a part-time job in retail to being gone all day, 6 days a week.
Yeah, right.
So you feel as if you missed a lot of milestones with your children.
I did, and I think the abrupt change in caregivers was hard for her. She's in her 20s now, but I blame myself for any anxiety issues she has, because obviously that was my fault.
No, you can't think that way.
Mom's always blame yourself. I know, you know how moms are. We blame ourselves.
I know, for everything, but I'm sure the flip side of that, I mean, if you could look at a silver lining, you becoming an NP or RN then NP, I mean, provided her a life that she wouldn't have had otherwise, you know what I mean?
A better life at that.
Absolutely. And she's really proud of me, which sounds kind of dorky, but she is. A couple of times when we've been out together, I've been stopped by former patient families who were very happy to see me, and she gets all mushy and happy because she's proud of me, which makes it all worthwhile.
Yeah, absolutely.
Yeah, 100%.
And she gets to have an example of, like how a mom should be, and how when things unfortunately fall for your family, how you kind of swoop in and you pick things up, you know what I mean? So I think for maybe...
And I didn't have much choice back then, because we were living on my ex-husband's Social Security. I mean, he was obviously my husband then, but Social Security and student loans. And so I needed to be able to pay for a house.
Yeah, absolutely. So, I mean, I guess I understand nothing we say maybe could flip that around, and most moms would probably feel how you feel as well. But I think that your daughter probably learned more good from that time than any bad she may have gotten,
I know. It's just the mommy guilt.
So here's the thing. Did your daughter ever go into nursing?
Good question.
No, she's not sure what she wants to do with her life yet, which is fine. She is, like I said, she's 22. She actually lives with me.
Yeah.
She just got done doing a year of AmeriCorps, which I was really proud of, which is sort of like the Peace Corps except in America.
I see.
So it's national service, helping underserved communities. And my son is finishing his training to be a glass blower.
Hey.
Scientific glass blower, specifically.
Oh, that's cool.
Nice.
That's
Yeah.
really, really cool.
So transitioning back to RN school, how was the clinical placement or rotations for you? How was that? Did you know that you wanted to go into a NICU prior to becoming a nurse?
Yes. Actually, when you apply for this program, you have to apply to the specialty.
Oh,
So I had to apply to be a neonatal specific nurse practitioner
I see.
to come in.
Oh.
So I knew that was what I wanted to do. But I did really enjoy my other rotations. more than I was expecting to,
Where were they?
even though there were big people. I was on a renal floor for my very first set of clinicals.
Yeah.
And I learned some very useful things like putting steroid tablets into empty gelatin caps because steroids are really bitter.
Yeah.
One of my lupus patients did that. She would like stack 6 of them in a big gelatin capsule so she wouldn't have to swallow them.
Yeah, right.
And then, let's see, I did a mental health rotation was at an inpatient hospital and at a teen drug and alcohol center that was also inpatient. I did a NICU, of course, because let's see, where else did I go? The nursing home one, which was my most uncomfortable one because I admittedly am uncomfortable with my own aging. And all the time it scares me.
Oh, terrifying.
Big time, yeah.
Yeah, that was a hard rotation. And we did community nursing. We went to schools and did some work there, which was cool. And then at a public health.
Taught some hand washing to the
I mean,
kids.
my school really does get really good clinical placements for everything I've done, honestly. And I had one bad clinical placement when I was in nurse practitioner school, and they would not use that hospital again because of what happened.
Really?
Wow. Okay.
Are you allowed to share what happened or no?
I can share in a vague sense. There was a patient that I think they did not treat as well as they should have and the way they should have because they'd made some assumptions about the patient.
Oh, no.
Which it wasn't acceptable how they treated her anyway. And their assumptions weren't even true. But that bothered me so deeply. I don't like people being discriminatory in front of me.
Oh, for sure.
I mean, I don't like them doing it at all, but especially not in front of me, where I have to feel like I'm part of it. And as a student, you're kind of stuck as a student because there's only so much you can do because you have no power there.
Absolutely.
And so all you can do is report it to everyone they let me report it to and tell them not to send students there anymore because that's not an appropriate place. You shouldn't have to deal with that on top of trying to learn what you're trying to learn.
I couldn't agree more.
Definitely. So with that situation, were you able to finish your rotation or did you have to stop halfway or a quarter through the way and then transition over to a different facility?
Nope. It was towards the end of my rotation, so I was able to finish, even though I was very unhappy because once I noticed that one situation, or I was part of that one situation, it wasn't that hard to notice. I could see a lot of other kind of systemic issues at their hospital. And so I decided to just try to make my learning experience from there of what not to do.
Yeah, that's smart.
Mm-hmm.
So do you, I know you took, I guess for most, what would be called like an unconventional route with the program that you were in, even though I think it's actually really cool. How long were your clinical placements?
I think we were on quarters then. The school has since changed the semesters, but I'm pretty sure we were on quarters. So they were 3-4 months.
Oh, that's actually...
And like psych, we split it between 2 locations. Community, we split it between 2 locations. All of the general nursing specialties they make you rotate through when you're going through it.
Yeah, so I think for me, because I'm currently doing my nurse practitioner as well too, I'm doing my family nurse practitioner, and it's roughly about the same.
Uh-huh.
We do quarters, and it's about 3 months for the rotations. There was something I wanted to ask you. With the NP, right? Yeah. So with your RN license, and this is a question that someone actually asked me, and I didn't really know how to respond back to them, but I feel like I gave them the right answer. So you obviously have your nurse practitioner license, which you have to renew. I would assume yearly, is it, or is it every 2 years?
Well, my board certification is every 3 years, and I think my state is every year, along with my nursing license. I think they do a yearly. It might be every 2 years. I have it on the calendar.
Smart. That's something I need to do actually. I need to, because I was almost late for my one of my licenses. So I work in Michigan as well as I have a Canadian license as well too for my RN. So on the Canadian side, I'm not sure if you know this, but we pay about $400 Canadian to renew our nursing license. However, in the
Yeah.
States, it's roughly about, I want to say maybe in the 200 range. 10 years ago, it
Yeah,
used to
that's
be 10 years ago, it used to be $200 Canadian on the Canadian side. So in 10 years, it's doubled, which is insane.
Wow.
Which means in another
That is
10
insane.
years, we might be looking at $800 Canadian on the Canadian side. However,
That
mhm,
uh,
yeah,
I'm annoyed by that, especially because we don't. I think we should have federal licensure in the
I
U.S.
agree.
agree.
Yes.
I could not agree more.
There is no reason that we have state individual licensure, and that I need to still send my transcript from college to each state when I move.
Yeah, I agree. And I don't know how it is for you guys, Susan, but here in Canada, when so the board that we renew with, they actually do nothing for nurses. Like they don't have any type of protection for nurses. They don't do anything. I mean, they do protect the public, and there's various ways they do that. However, so we pay this $400, and again, this board does nothing for us. They just let the public know that we are certified as nurses, and this is the board we have to pay with. Is it the same way for you guys in the States? And what I mean by they don't do nothing, so as an example, let's say if a patient ever wanted to sue me for something like negligence or malpractice or something, the board doesn't provide like uh, a lawyer, for example, to protect me. That's something, in addition, I'd have to pay another board.
Right. That's the same thing in the U.S. The board is there to protect the public from us.
Right.
Really.
And it's
So
just
you pay all the money.
sorry.
Oh, God.
Go on, sorry. You there?
Oh, I'm sorry. Was it to me?
Yeah,
Go on.
ahead.
Finish what you were saying. My apologies.
Oh, it's ridiculous because I understand that having it duplicated in every state is just insane, and it allows bad nurses to slip through the cracks.
I agree.
Mm-hmm.
Because if they miss that someone has a disciplinary action in some state and they move to another, I just think it's frustrating that they don't provide much, and that they also, like in California where I am, you have to take a mandatory drug class about drugs of abuse, which I wouldn't mind if it was somewhat geared towards neonatal.
Yeah.
But it's all questions about adult medications and discussions about how to prescribe Suboxone and methadone as an outpatient. Well, if I ever do that, I'm violating my license to begin with. So
Yeah, absolutely.
we're in a whole other world of trouble that you're requiring me to do this $200 class.
Yeah, that's insane.
That's crazy. So yeah, that really has nothing to do with the specialty that you're in, but it's required mandatory for you to do on a yearly basis, is it?
No, that was actually just to get my license initially in California.
Got you.
Oh man.
Luckily, I am exempt from most of the silly schedule drug issues because I only prescribe inpatient, so I don't have to worry about patients doctor shopping.
Yeah, right.
babies are really poor at that.
So before we go into a quick break or intermission, how much do you pay for your you said every 3 years for your NP license, and then your RN is every year. So in total, how much is that typically?
So I think my specialty is somewhere around 300, 400, something around there. And then I get my DEA for free because I work for a state university hospital.
Nice.
And then it's a couple $100 for the nursing, couple $100 for my prescription, and then a couple $300 for my nurse practitioner, I think. So I'm pretty sure those are every 2 years, not every year.
Gotcha.
The nursing and nurse practitioner one.
Man, that's beautiful.
But it's still a good chunk of change.
Oh, for
It
sure.
is.
Especially because you probably paid it like all at once and everything. Like, so this year, I'm embarrassed to announce that I was late to pay for my nursing license, like my renewal. So, and my wife's also a nurse, so she kept reminding me, like, "Yo, don't be late. Don't be late." And so it is on top of 400. Like, so it's 400 for the license, and the late fee is $150.
Insane.
So I had to pay $550 this year just to renew my license.
Mm.
Wow.
Yeah.
That's a lot.
Yeah, and 400 again by December 31st.
and once
Yeah, and I used to have licenses in other states, and then you can't afford to keep licenses in a lot of other states.
Yeah, that's right.
it's wild. It's wild.
And this is the thing. So this is also part of the reason I agree with you with the federal licensing. I mean, I don't know why it's not already a thing, but my wife and I both worked in Australia. And in Australia, that's exactly how it is. And it's only like $150.
Simple.
So you pay $150, you get federal licensing, and you can work anywhere in any state, any city, as long as they'll take you on.
Simple as that.
And that makes so much sense.
Absolutely, because it's not even like things really change from state to state or city to city. All the dosages for adults are still the same. Everything, or even neonates, like everything stays the same no matter where you go, as long as you're in the same country.
Right.
Right, and I feel like if you're going to move to another state that has some sort of weird rules about nurses and what they can do, that's your responsibility to know them and
Yeah, that's right. So
know what your scope is.
exactly. So over there, they kind of had the same thing. So I think the only difference was they had different rules for indigenous nurses, not necessarily with patients. It was just like good to know things, you know? So they kind of make you take an online module, and that's through the licensing board. So it's completely free. You do this online module. It's a requirement if you want to work, depending on whatever state has it. But it takes you 4 to 8 hours to do it. It's free, and if you want to work in a different state, I'm sure you're happy to do it. You know what I mean?
Yeah, that's much more reasonable in my opinion.
Yeah, I couldn't agree more.
One thing I wanted to ask you was the challenges you faced starting off with the nurse practitioner program. Just curious about that, and then how you were able to transition once you started working.
Well, the transition is the hardest, I think. And it was interesting because I was just talking to one of the hospitalists I work with currently, who's now moving into a fellow role. And it's very similar kind of role change issues that you have when you're moving from bedside to nurse practitioner. But I think it was just a lot of information, number one. My program, I think, honestly, was very, very good and very pathophys heavy, which is very good. Lot to remember, obviously. And just always feeling like you're not good enough to do this. And then once you're starting, I have to say I was really, really lucky. The first place I was a nurse practitioner was incredibly supportive of new grads. I always felt that the nurses, the doctors, the other nurse practitioners were all on the same team as me, trying to make sure that I succeeded. And that was not my experience at my hospital where I was the bedside nurse, which is why I didn't stay there. It was one of the most functional units I've worked on. It was amazing. But it was in Texas, and it's hot there, and I don't like the heat.
Oh, that's funny.
So my unit is maybe a little less functional than that one right now, but it's not as bad as some of the other ones I worked at, but the weather's great. It's enough to make up for it.
I'm sure it is. Better than us
and
now.
I think, and I think for switching from the nursing to the nurse practitioner role, it's having to get used to not knowing everything about your patients. So when you're a bedside nurse, you have 1, 2, maybe 3 or 4 in the NICU patients, and you know everything that's going on with them,
right,
head to toe, every shift. And when you have 7, 8, or 9 patients that you're caring for, you can't know all of that.
Oh, for
you will
sure.
drive yourself crazy
For sure.
if you try to know everything the bedside nurse knows. And that's where you really depend on the bedside nurses as a teammate to be your eyes and ears for that little minutia that you can't see anymore.
Yeah.
Just like the doctors rely on us, because especially in the NICU, we're very collaborative, and it kind of just goes up as nurse practitioner, then you've got your fellows and your doctors, and we're each kind of zoomed out more, and we each rely on the people that come before us to know more than we do.
Yeah, right. So what would you say
about the patient?
Going from like an RN to an NP, what was, I guess, your biggest surprise, like what you didn't expect that you got out of the profession?
The connections I would make with the families, honestly.
Really?
So, especially when you're new, I often same as nursing as a new grad, but we had to work days to get used to doing all the craziness that happens during the day. So you really build a bond with your patient families, especially in the NICU, because they're all there for so long.
Yeah.
And so I have patients that I still get the occasional updates from their families that I took care of, God, it's been over a decade now. And
wow.
Some of them no one thought would survive, and now they're doing great. And some of them are gone, and their parents gave me pictures to keep. And those are just as meaningful because, you made a difference in that child's life, even if they didn't get to go home.
Wow.
Yeah, that's tough.
Yeah.
I actually have in my house a wall of things that don't suck, which is pictures of patients and notes that I've gotten from families and students. So on nights when I think that everything in nursing sucks and everything to do with the NICU and everything is just terrible, I can look at my wall and remember, okay, you are doing good things. There is a reason to keep doing this.
Right.
Everything does not suck. It's not as bad as you think it is in this moment.
Yeah, that's fair. That's actually a really nice reminder because everything sucks in adults. Everything sucks, Susan.
Everything sucks with the babies too. It's just in a different way.
Yeah.
We are so depressing as a unit.
Yeah.
That's why no one wants to work in the NICU.
Man, it's tough. I can't even imagine. Again, I know this is something we already said, but like that difference, I can't imagine going on to and just dosages, having to starting an IV. I'm like on a this little baby that's not even the size of my hand. Oh man,
IV, my goodness.
Oh my God, it's so easy. You can see through them.
Easy.
We use a light to see through them.
That's crazy.
And then you can just put the IV in.
That's hilarious.
Easier said than done.
I can't feel for a vein.
You know what I think?
Feeling for a vein is weird, but you can just this little light. It's amazing. You just shine it through their skin, and whoop, there's the vein.
That's crazy to think. I've never even thought about that.
Yeah, I've never thought about that. But it's just for me, I think the fear of just seeing them cry and just being in pain. But then again, adults, I mean, I've seen a few adults cry when you
Adults be
start
crying,
IVs. But it's
shut
different.
up.
Yeah, man up. Thug it out. What do you do? What are you doing?
I don't know.
You know? Just being honest.
Oh, that's hilarious.
I will say this is one of the stories I have from when I was in nursing school. I was at an adult ER,
Yeah.
so that was interesting. And I had to try to find. They sent me in to put in a patient's IV who was there for suicidal ideation, and so they wanted me to put an IV in him. And he really liked me trying to find an IV. And he was kind of doughy.
Yeah.
So I kept having to feel his arm, trying to find a vein, which I couldn't do. And I finally came out and I'm like, he's moaning in there and pitching a tent and I need to leave for a little bit. They sent a male nurse in later. He didn't enjoy the male nurse much.
Yeah, you get a lot of those in adults too. Just, I don't know, odd personalities, I guess.
Well, yeah, he was mentally ill, so whatever. But yeah, that was not something I have to deal with babies.
Yeah, that's true. So here's the thing: would you consider one of the more difficult parts of your job then dealing with families?
Yes. Yes and no. I mean, some of it is just dealing with the crushing despair that we deal with sometimes. And then sometimes it's the families that are kind of tying into that. Like they really, for very understandable reasons and completely logically, do not want to have their child die, no matter what.
Of course.
And sometimes it's hard to get them to understand that it's not a matter of whether the child is going to die or not. It's just, how is that going to happen? And sometimes when they insist that they want that to happen in the most traumatic way possible for the child, that can be real hard to take.
For sure.
Because they're like, I don't want to ever remove the breathing tube. I don't want to ever stop doing anything, which means that we are going to code the baby to death.
Yeah, right.
And no one wants to do that.
Of course.
We'd rather, in those cases, have the baby be held by their mom and dad and be loved on and have peace and not all of those noise and yelling and pushing on their ribs and breaking them, and just like you are with older people, I'm sure.
Oh, yeah.
That's why I have a living will.
Oh, wow.
Again, uncomfortableness with my own aging. I'm like, I do not want to be a full care person. Let me go.
Well, I mean, I think it also depends, like, the time that we're living in. Like, we get a lot. So I work on a surgical unit, and we get a lot of patients that, I shouldn't say a lot, it's not a lot, but we do get patients that probably should not be getting the surgeries they're there for. And on top of that, they're like very frail, ill. I mean, a lot of the time they're older, so there's not much life left to live. And then because, again, families, of course, want their grandparents, their parents, their great-grandparents there. They want to love them. They want to make sure they're okay. And they want them to live. They make them full codes. And it just gets tough on the staff knowing that we're about to put their bodies in shock and they may not even survive the surgery, but then they come up to the unit and then we're like, okay, we're probably going to have to code this 98-year-old frail woman, and who's going to do the chest compressions? Because I'm 300 pounds. If I'm getting on grandma's chest, it's going to be a very uncomfortable situation, you know?
Yeah.
Like, so.
Yeah, and I mean, kudos to you for being able to do that. That just is stuff of nightmares.
Yeah. And then there have been times where, like, we have to, because as nurses here, we're not allowed to really talk to family about changing a patient's code status. That's for the doctors and NPs to do. So there's times where we're like, okay, this patient's declining. There's still a full code. Can you talk to the family again? Because make them aware. Like if they code, we have to do everything we can to save their lives. And it's again, I know it's an uncomfortable situation, but I'm like, we got to think about this logically too.
And just from the provider's perspective, sometimes it doesn't matter what we say.
Oh, for sure.
They still insist on doing everyone because Meemaw's a fighter.
Oh yeah, right. And it's tough. Like, and how do you educate like a family member that just wants their mom, grandma, whatever there, and you're looking at things from like the point of view of a medical provider? Like, how do you educate a family member that way?
I try to focus on kind of what their goals for their child are for the future, and things that they may not realize, like they're never going to be able to see, hear, taste food, enjoy life. They're going to get painful surgeries their whole life. And unfortunately, pain is one of those most basic functions in our brain, because pain is so important that if you have any brain left, you have pain receptors.
Right.
And so sometimes you have to do, as a parent, you have to do things that are going to hurt you deeply for the better of your child. And it sucks. And you are taking on the pain for your child.
Right.
That's usually, I also find that being direct, because it's hard to be direct.
Oh, for sure.
Yeah.
And some families don't like it, but more, I feel, really do, being clear that we're talking about death.
Yeah.
And when we're worried about what their future is going to look like, that means that we are worried that they will not have any meaningful consciousness.
Of course.
And because parents, they hear those words and they don't mean the same thing to them as they do to us.
Yeah.
Because we try to be gentle around it and walk around it and ease them into it, which is good sometimes, but also sometimes it allows them to think that, well, I also think sometimes it's put too much on the families.
Yeah.
And they're not educated enough to be able to understand everything that's going on. And I feel in some ways that's why doctors get paid more, because they're taking on a lot of responsibility, including helping to guide people.
Right.
Instead of just saying, you could do A or you could do B. What do you want to do?
Right.
Mm-hmm.
Saying, I think it's time we need to do A. Do you have any questions about why we shouldn't do B?
Right. Well, as an NP, I know you said this is why doctors get paid much, but as an NP, are these conversations you have to have as well?
Sometimes, depends on your rapport with the family and what's going on. I find, obviously when there's a code happening, like a real code, everyone's kind of swarmed around the bedside. And if it's not my patient, you're kind of standing around, for lack of a better word. And I try to be the kind of person that helps guide the parents and talk to them about what's happening.
Right.
Because obviously their primary, the doctor, the attending the fellow, the person the nurse practitioner who's actually caring for the patient are all in there working on them, trying to bring them back.
That's right.
And I can help keep them updated to a point where if they want to say stop, I can get the attending to bring them over to talk.
Yeah, right.
And I try to help remind people that, the family is there, or if they're not there, that we need to call them,
Right.
depending on the situation.
Definitely, definitely. Once again, to piggyback off on Anthony, you mentioned physicians pay. Are you able to tap in or talk a little bit about the transparency with nurse practitioner pay?
It's very transparent where I am because we are all state employees, and so it gets published on the internet exactly what we made the last year, and anyone can look up our contract, at least for nursing. But it also lists what the attendings made, and I mean they do make more than us, obviously.
Right.
They have more responsibility than us. But it is interesting to know. It's very interesting having come to California where there is very strong union, which has its ups and downs, but there is definitely transparency in pay out here.
So even with unions over there, do you guys have a union for NPs?
No, we're in the nursing union.
Yeah,
we're
right.
kind of tacked on the edge.
Oh, I see. I didn't know that. Because over here, our NPs aren't unionized. Yeah.
And that's really, I think it's only in California, and we weren't originally when I first started working out here.
Yeah.
And it was a change, and it brought when we switched to have it, we actually had to join the union because of contract negotiations. And there were some good things, like we got pay differentials if we work nights and weekends and holidays. But we also got less vacation time and less flexibility.
Yeah, right.
Yeah, so with NPs, I'm seeing, so I don't know if it's been like this for a while now, but a lot of the current NPs that I'm meeting or have met, they've been an RN for a couple of years. They decide to go into the NP program. Once they finish, they realize, this just isn't for me, or the pay isn't where I thought it would be. So let me go back to working bedside. That's one of the main reasons why I was asking about in terms of pay transparency, especially in California. I would imagine a lot of the NPs out there would get paid more, but yeah, just interesting to me.
Yeah, the nurses get paid a lot too, and we have some new grad NPs in our group right now. One of which who almost just quit, and that was more about just those first year pressure that you put on yourself. And so we were able to talk to her and reassure her, because she's actually a fabulous nurse practitioner. She just needs the confidence and time, because we all are like that when we start out.
Right.
And I think the difference is, it's the pay when you start out as an NP is close to an experienced nurse. But that's your basement. You can go up from there. And for the nurses, it's, for the most part, they're upper level. Yeah. And for me, I will say, I like doing the job that I do as a nurse practitioner. I like doing the stuff at the bedside, being able to cuddle the babies and feed the babies and all of those things. But I like making the advanced decisions and doing procedures and helping in other ways. I'm a big proponent that if you want to go into school, you really should know what niche you want to go into. And do everything you can to focus on that niche, because that will make you the most successful professionally.
Absolutely.
And that's what I tell a lot of people who are thinking of going into the nurse practitioner program. I have a couple of friends that are thinking about going in it as well too. And I tell them, you gotta know what niche you're trying to get into, or the specialty per se. I know one individual who wants to get into psych, but I'm like, have you ever done psych? Have you ever had a rotation in psych? Have you ever worked in psych for at least a year to 2 years? If not, you might want to do that first before you hop into going into the psych NP program. I
completely agree.
Yeah. I feel like a lot of people are just doing it for the money and they're seeing people on social media, whether it's TikTok, Instagram, they see that they do it, so they believe that they can do it as well too. But you got to really have that experience before you make that decision per se.
And I think you need to know what that role is, because it's a very different role from being at the bedside.
Right.
And it's mostly paperwork.
Yeah.
It's paperwork with some procedures.
Yeah.
And so you have to be ready for that as your role, and the different ways it will strain you then as a nurse. And I agree that some people just think that that's the next step to take if I want to make more money. And I think there's probably better ways to earn more money.
Yeah, right. Definitely. So would you say with the NP, it's more so mentally challenging as opposed to physically, I would assume?
Yes, very much so. I mean, especially I work nights, so I'm not doing a lot of the assessment for rounds and things like that. I'm putting out fires at patient bedsides and dealing with new admissions and things.
Mm-hmm.
But, I'm not doing a lot physically with the patients. I go and assess them when I need to, do procedures when I need to, but most of my job is thinking and making decisions. And you can tell when I've had a really bad day because I get home and I'm like, I don't want to make any more decisions ever. I have people asking me things all night, and I cannot answer any more questions, even if it's whether I want to drink something.
Yeah, absolutely. So could you, I know you've been talking about procedures. Can you give us like some sort of, I guess, insight into some of the procedures that you would be doing?
Right. Yeah, good question.
Oh, yeah. For neonatal, we have our bread and butter is always umbilical lines. And I am the fastest line from the West.
Hey.
That is the one skill I'm very proud of.
Yeah.
Lumbar punctures, central lines, picks, chest tubes, chest needling, burn centesis when they have a pneumo, paracentesis, so belly taps when they have ascites, especially when it's bad. Most of the time, surgery does that, but when they come out with ascites and you need to relieve pressure so they can breathe, we'll do that in the delivery room. Wow. What else do we do? Technically, we help with exchange transfusions when those happen, which are thankfully very few and far between these days. Suprapubic bladder taps, which we almost never do because no one wants to do those because they seem horrible. I feel like I'm missing something. Oh, intubation, of course. Yeah. That's the other bread and butter.
Yeah.
So for someone who's thinking about going into the same specialty as you with neonatal NP, these skills that you just explained, is this something that you were able to get firsthand experience while you were in NP school, or did you have to pay for, I guess, a class on the side after you graduated or while you're in school just to further your skill set and education?
No, it was it was clinical. It's kind of, I believe in nursing school too, you have the clinical portion and the didactic that goes along with it. Part of that is lab, and labs were practicing these skills. I did have to take a specific class on PIC insertion.
Right.
But I believe that was provided for through the school. And the rest was just practice. And honestly, the biggest thing that I say to the new nurse practitioners who are coming out and are always nervous about their intubation skills or their LP skills or their line skills, anyone can be taught to do the skills.
Yeah, right.
Your value is not in being able to get that line to whatever. The value is in the brain and the decisions we're making to get there. Right. You get there and everyone says, oh, we need to intubate this baby. And then you look and you realize that they've compressed the airway and maybe if you straighten out their airway a little bit, you don't need to intubate.
Yeah, right.
Or they think that the baby's doing fine. Or I once went, so I also do interfacility transport. So I go to other hospitals to bring them back to my hospital.
Mm-hmm.
I walk into an adult ER who has a baby with RSV. And they're like, oh, that he was doing terribly, but I think he's doing better now because he's not breathing so fast. And yeah, you're laughing because that means the baby's about to stop breathing because he's still retracting to his backbone.
Yeah, that's right.
And the ER doc thinks that things are getting better, and they really weren't.
Yeah.
So that's what we're there for, to be able to say, no, this baby is not getting better. We need to escalate support, not relax.
Right.
So do you get a chance to do you ever have shifts where you would help out in the ED then?
Oh, well, I mean, as soon as I go to a place, whether it's a hospital NICU or their ER, I am technically kind of the ranking person there.
Okay.
For my patient. I don't deal with anybody else there.
I got you.
But for my patient, I'm now doing all of the orders. The ER doc is helping me. And so, sometimes I'll have doctors ask if they can try an intubation, and I will sometimes let them. But it depends on the patient condition and how well I think they're going to tolerate a potentially not very good intubation attempt.
Yeah, right.
One of the last few questions I wanted to ask was the pandemic.
Mm-hmm.
As a nurse practitioner, how did that affect you and the facility that you're in when the pandemic happened?
That was rough because obviously babies were not really affected by COVID very much.
Right.
I mean, occasionally some babies would get it. They're very rarely symptomatic. But of course, our staff could all get it.
Mm-hmm.
The parents could all get it. And when COVID first hit, no one knew whether the babies were going to get sick or not. And it was really hard because there were a lot of restrictions on parents coming to the bedside, some of which I didn't always agree with, because if you have two parents that live together, there's no need to limit to only one.
Right.
They're getting exposed to the same germs. And I remember a case early in the pandemic where there was a micro preemie at a outside hospital who had a devastating bleed, and I wasn't sure we would be able to get it back to our hospital anyway. But the hospital they were at allowed the parents to both be there since mom was there as a labor and delivery patient.
Right.
And if we had taken her baby to my hospital, only one of them would be able to visit the baby.
Oh, my God.
And that convinced them to do end-of-life care where they were instead of transferring, because the reality was there was not anything more we could do at my hospital than what they were already doing.
Yeah.
Wow.
And having to be alone in doing that, I know we had some situations. I don't remember them super clearly now for the most part, but I can't imagine having to go through that without your partner.
For sure.
Or a support person if you don't have a partner. And it was just, for me, I feel almost guilty because I didn't have the negative COVID trauma, or the same trauma that everyone else had. I worked a lot.
Yeah.
And that's basically all I did. I worked, I went home, I ordered takeout. And so we would have staff calling out, but I didn't get COVID for the first time until this past year.
Really?
Wow.
And yeah, I went on a cruise.
They'll get you.
That'll do it. That will do it.
My last day, I started having body aches, and I was like, "Oh no!"
Well, at least you got to enjoy most
I'm like,
of
"This
it.
is either flu or COVID."
Oh,
Yeah,
no.
that was good. But I actually had more money during COVID because I was working all the overtime.
And you couldn't do anything.
I couldn't do anything. I was just home and I was watching a lot of TV.
So did the
I'm thankful for my cat.
did the rates go up for you guys, like every other specialty, or
The what?
the rates? So like your pay?
Oh, our pay didn't really change, no.
Because you mentioned a lot of individuals were calling out sick. Granted, they probably were sick, but I know when I was working in ICU,
Yeah, they were.
I know when I was working in ICU around that time, they would bump up the rates higher than what they were. So just for an incentive.
Well, we were
people to
union by then, so we would get overtime pay. So that's time and a half or double time, depending.
Got you.
And in Northern California, you get paid a lot. So
Yeah, it's true.
when you're looking at doubling that, that's a lot of money.
Yeah, for sure.
And sorry, one more thing, Ann. To add on to that question that I asked, I'm sure there were many not factors, but hurdles that you guys had to go through working in the NICU around that time. Like you're dealing with premature infants, right? So I'm sure every staff member that came onto that unit probably had to get tested for COVID. Am I right? On a daily basis, maybe?
At different times, we had no, but if you had any signs of illness, you had to do. We had a vending machine of tests that we could get, and if you did anything that was considered high risk, like going in to a doctor's office or anything where there was basically more than one person, you were supposed to be testing.
Wow.
And that was after the first time when no one could get tests, but and if you like any symptoms, they were very much encouraging people to stay home, and they did.
Okay.
Because we actually at one point did have to close down our ECMO program in the NICU for like a week because it was later in the pandemic, but all the ECMO nurses had gone out to eat together.
Oh my God.
Damn.
And somebody had COVID.
Holy crap.
So I think it was like a baby shower, and most of the ECMO nurses were there. And if you don't have anyone to run the machine,
you can't run the machine.
Yeah.
you can't take any patients.
Yeah. Wow, that's terrifying.
So how long were y'all shut down for, or how long was the ECMO?
I think it's 7 days, maybe 10.
Wow.
So 10 days, my goodness.
Well, we kind of had something similar. I mean, not ECMO, but a lot of the EMS staff here, I guess that like someone had like a house party during the pandemic. and they all got sick. And and at the time, obviously, things were crazy. People were coming to the ED. Like, we were just so inundated. We had to go into, like, a few code blacks and everything.
Wow.
And so I believe one time they had to call a code black because they did not have enough EMS staff because they went to this party and got COVID. Yeah, like, it was nuts, man.
That's wow. What a time.
Like, it's just crazy.
And then my other question, so were there situations where mothers would come into the hospital, obviously, ready to give birth, but they tested positive for COVID as well, too? Was there any guidelines or anything significant that happened in a situation like that?
There were lots of rules. All the laboring mothers get tested. I don't know if they still do, but they were getting tested. So when they came into the hospital, they got tested, and we had this whole setup. If mom was COVID positive, she had to go into a special OR that was kind of the COVID OR. Wow. Even if she was delivering vaginally, she would do it in there just in case of problems. Wow. And we had 3 teams that would take the baby, a dirty team, a midway team, and a clean team.
Wow. My goodness.
So someone who was in full PPE, and they would put the baby in the isolette. And the kind of the middle team would be able to later join the clean team after they, took off the rest of their PPE.
Yeah, right.
But they tried to keep the dirty team away from having to they usually didn't come back in to take care of the baby. They went in to do other stuff.
Yeah,
Right.
right.
Okay.
Wow, that's crazy.
Now we don't do it as much.
Yeah, well,
Like,
yeah.
I mean, we don't do that. We just know and wear N95s if mom has COVID, but thankfully it doesn't happen that often because we
Yeah.
all hate wearing all the PPE.
Oh, yeah, absolutely. So, I mean, it seems like you've had the opportunity to work in quite a few places. Barring weather, if it was just based on like city and facility, where would you choose and why?
Facility in Houston at Texas Children's Hospital.
Mm-hmm.
They have an amazing program. It's large. It was incredibly stressful, but I learned so much there. They have great nursing, great doctors, great nurse practitioner team, very supportive. They're constantly updating their practices with the most recent evidence. They're very evidence-based. I loved everything about it except the fact that it was in Texas, both kind of politically and socially,
Right.
and weather-wise. Otherwise, San Francisco probably.
Yeah.
I love living in San Francisco.
I can imagine.
I would put up with a lot at a hospital to be able to live where I do.
Wow. That's good. That's actually good to know.
I have a view of the ocean from my bedroom.
Lovely.
And coming from Ohio, I never thought living near an ocean would be so important to me. I never want to live away from an ocean again.
Oh, man. I've never
so
lived near
great.
an ocean, and I want to live
Yeah, I would love to.
Yeah.
I would love to myself. Yeah.
You know?
You're having a bad day, you can just go to the ocean and walk on the beach for a little while.
Oh, I guess that's true. That's how
And-
when we lived in Australia, that's how it was for us.
Mm.
Just every day, every morning, every night, you get to walk on the beach.
And somehow, I don't know, I just find the ocean very calming and reassuring.
Oh, for sure.
So, have you ever thought about potentially doing travel nursing? So we kind of talked about it off air where you were thinking about maybe doing Vancouver, but obviously there'd be a bunch of hurdles and obstacles that you'd be facing. Have you thought about any other locations maybe in the near future?
Well, speaking of COVID, I had actually was looking into what it would take to go to Australia to practice as a nurse practitioner,
Oh, wow.
and had this big vacation planned where I was going to be visiting hospitals in Sydney and Adelaide and Melbourne, and it was for like 3 weeks, and I was supposed to leave on March 16th, 2000.
Oh, no.
So in February, I saw things. I didn't like what I was seeing on the news, so I was able to get everything canceled before. But I haven't been able to make it to Australia yet.
Oh, man. If I could give you one piece of advice, it would just be go. Go. Everything you've talked about, I think you would really, really, really love it over there.
Yeah, the only thing I worry about is kind of how the nurse practitioners work there. And I am spoiled by the resources in the U.S.
Right. Well, one thing I noticed when we lived over there, I feel like really working over there gave me a new appreciation for the nurse practitioner. I feel like over there, they were so respected. Like just, well, one, the pay is amazing. They were very respected. And I never really saw an issue with resources because over there they have a public and a private system. So you have the option to work in either or both if you want to. Obviously the public, you deal with people that are just in like low income areas and everything that is associated with that. And then you have the option to work in the private system as well. And again, everything that is associated with that, just better resources, better facilities, better everything. But I think what stood out above and beyond, like, so as an example here, I would say, even though the NPs do absolutely get respect, but I can only speak specifically for Windsor, I feel like NPs get dumped a lot of things on, I feel like. So they get overworked and underpaid. So you do a lot of the things that a physician would have to do, but you don't necessarily get the associated pay with it. Whereas over there, there's a very clear line on what the NP does, what the physician does. However, you get a lot of respect. I feel like a multidisciplinary team really works that way over there. And I don't know. I just, like I said, if it's still something that's on your mind, I would say go. I think it would be a great experience.
I do want to still go. I do feel that NICUs in general value their nurse practitioners probably more than anywhere else. There's definitely times, no shade to residents because they're working really hard and they're being thrown into new situations constantly.
Absolutely.
But sometimes when the shit is hitting the fan, it's nice to have someone who only works in your unit and isn't here just for 2 weeks and then has to go to the next one. So knows where everything is, how everything goes, and what to anticipate is coming next, which the residents, since they're still learning, and most of them will have, 3 weeks in the NICU every year, they just are not going to be able to have that experience. And so I feel the attending physicians really find us vital for functioning on the unit.
Yeah, right. Definitely.
And the nurses appreciate us too because we tend to be a little more responsive sometimes.
Oh, for sure. Always. At least from my experience, always more responsive.
But like I said, I do love the residents. It's just they're in a different place in their career.
Yeah.
And a lot of them don't want to be in the NICU, which I respect. I would feel the same way if I was in whatever they want to do.
Yeah. And I guess my last question, and this is usually a question Junior asks, so I wonder if this is maybe one of the things he was going to ask, but if you had an option to talk to your younger self, let's say even before you started nursing, or when you just started, or even just started as an NP, what is one piece of advice you would give to yourself, or maybe somebody that's new starting out now?
Oh, wow, that's a hard one actually. Maybe to myself to do nursing earlier. But I don't know. I part of the reason I went into it is that both of my babies were premature before I was a nurse.
Oh, okay.
And that's why I kind of knew about neonatal.
Right.
But try to put yourself in the family's shoes when you get frustrated with them. That's always useful. And be patient with yourself.
Yeah.
Because none of us are ever perfect.
Yeah.
And always ask questions.
Definitely. 100%.
You're never going to regret asking questions.
I agree.
Definitely. I think that's one thing I would tell to someone as well too.
Yeah.
Don't feel shy. Don't be afraid. Be confident, and don't think any question that you have in your mind is a stupid question.
Yeah.
You know what I mean? So that's very key. I like that one.
Yeah, if you don't know it, you need to know it. And sometimes that question doesn't need to be asked to another person. You can look it up yourself,
Right.
depending on what the question is. But don't ever be that person who just says, oh, the patient has this diagnosis. What does that mean? I don't know. Find out what that means.
Absolutely.
Right. Definitely. Now, what about someone who's thinking... Sorry, go ahead.
I was just saying, I would see that in nurses, and much less often with nurse practitioners. They just kind of stay on that upper surface, and that, I think, is a detriment to care because they can't anticipate the needs of the patient as much.
Yeah.
Right. Now, what about someone who's thinking about going into the NP program, specifically the neonatal specialty? What advice would you give someone who's thinking of taking that route?
School is going to be hell because it's chaotic and we're all type A personalities. And so we don't like chaos. But be patient. It'll get better. that's really your watchword is be patient. It'll get better.
Yeah.
And if it's not getting better, try to find it. Not all hospital units are the same. I do know someone in my class who went to work at a hospital that was not very supportive of new grads, and she did leave the role of nurse practitioner, went back to the bedside, and never practiced again. But that's a toxic way. And after you're not new anymore, support the people coming up.
I agree.
Yes.
It only helps you to have talented people around you
I agree.
and people who know what they're doing.
I agree.
Yeah. Well, I think that's about it. Honestly, thank you so much, Susan.
Yeah, thank you so much for taking the time, Susan.
Thank you so much for
appreciate
asking
you.
some questions and stuff
Yeah,
Yeah.
absolutely.
and listening to me
Absolutely.
ramble on.
We've learned so much, honestly. I've learned so much.
Yeah.
But
And be a neonatal nurse practitioner out there, because there's a constant shortage of neonatals.
yeah, that was another question I was going to
We
ask. I believe it.
Yeah, we have one of the longest programs. We require experience, and we're a really good pressing specialty. So we don't, and there's not as many schools.
Yeah.
So we definitely are always shorthanded everywhere in the country and the world. And we're the most established. Like, most hospitals know what to do with us.
Yes. I could see that.
Yeah. Lovely. Well, thank you so much once again.
Yeah, thank you.
Thank you so much for having me.
So we'll wrap up this episode. Thank you for tuning in.
Yes, sir.
Make sure y'all like, subscribe, comment on YouTube, Facebook, Instagram, TikTok, all that. Tell a friend, tell another
To
friend.
tell another friend.
You know how it goes. And that's about it.
All the friends.
All
There
the
you go.
friends, yes.
There you go.
Alrighty.
Peace.